Good afternoon, everyone. Welcome to our webinar. So good afternoon, everyone. I want to welcome you to our Urban Future Leveraging Health Ecosystems for Community Change webinar. I'm Dr. Jacqueline Orr. I'm a Senior Program Officer for the National Health Team at the Kresge Foundation, and I'll be your moderator today. I wanted to take a few minutes to set the stage for the webinar and introduce our panelists. This year, we celebrated the Kresge Foundation's 100th anniversary in our ongoing efforts to expand equity and opportunity in America's cities. In September, our American Cities program team hosted a powerful coming together where many of the nation's foremost hands-on urban development practitioners could exchange ideas, extend their network, and replenish themselves while collectively advancing the direction of the community development field. Together, we celebrated progress. We also discussed lessons learned and prepared for the future. And this wonderful group of panelists was scheduled to be at our September convening to discuss the H3C apartment development, as well as other collaborations. But Hurricane Francis threw a wrench into those plans. So while many of our colleagues from New Orleans were able to attend, we made the decision to cancel our panel to ensure that our panelists wouldn't be stuck or stranded if the weather took a turn for the worse. So given the amazing work that's happening in New Orleans and in the region, we wanted that they're doing together. We really wanted to partner with them and have a conversation before the end of the year to discuss the larger New Orleans ecosystem as well. So we definitely wanted to give them an opportunity to share their hands-on experiences. And now I'll give a brief introduction of our panelists. Shalina Davis, she serves as the Chief Executive Officer of Louisiana Public Health Institute, where she oversees the LPHI team and offers strategic direction to ensure health and racial equity and champion health for people within systems and throughout communities. Shalina brings over 15 years of experience in the public health and healthcare systems, into public health and healthcare systems, leadership development, and health equity to this work. Shalina holds a dual master's in public health and social work from Tulane University Schools of Public Health and tropical medicine and social work, and a bachelor's of science in psychology from the wonderful Xavier University of Louisiana. I'm a little biased. I'm also a graduate of Xavier. Dr. Michael Griffin has served as the CEO and president of Ascension DePaul Services of New Orleans since 2008, where he's responsible for strategic planning, development of objectives and policies, and budgeting. Michael completed his Bachelor's of Science degree in Health Management at our rival, Dillard University, his Master's degree in Health Care Administration and Management at Meharry Medical College, and his Doctor of Science degree in Health Leadership at the University of Alabama, Birmingham. Finally, last but not least, Kathy Laborde is the Gulf Coast Housing Partnership President and CEO and provides overall leadership to GCHP, overseeing the organization's project pipeline, financing, construction, asset management, and property management activities. Over the course of her career, Kathy has developed more than 7,000 affordable and market rate homes in commercial and community facilities, both directly and in partnership with local nonprofits, city and state government, and the private sector. Kathy holds a Bachelor of Science in Economics from the University of Pennsylvania Wharton School and an MBA from Tulane University. Please help me welcome Shalina, Michael, and Kathy to our webinar. So just to give you guys an idea of the time that we'll spend together, we'll spend the majority of our time giving Shalina, Michael, and Kathy an opportunity to share their work and leave about 15 minutes for Q&A. So if you do have a question, feel free to drop that in the chat for us, and we'll address those at the end of our discussion. Now, let's dive in. We're here to talk about how community institutions in New Orleans, which is one of Kresge's 4 focus cities, how they're leveraging leveraging intersectional efforts to transform and address health as a driver and determinant of health in the region, and what can other places learn from their efforts. So to get started, Kathy and Michael, can you discuss the H3C partnership and how that developed?
Sure. Thank you very much. And good morning or good afternoon to all of you. Just for context, GCHP was created after Katrina. Our office sits on Aretha Castle Haley Boulevard in New Orleans. And for those familiar with the boulevard, it was a blighted thoroughfare that we were committed to transform along with our community partners. The mantra for the redevelopment of the boulevard through many, many decades of community planning prior to Katrina was commerce, culture, and community. So it was in that context that we began our work. And frankly, a lot got done, but we really did need to connect with the lower side of the boulevard, getting closer to downtown to make sure we had sufficient foot traffic to support the investments that had already been made. And just by a fluke, a significant parcel came on the market. We and another community partner, Lembic, decided it was too important for it to fall into anybody else's hands other than the community. So we purchased it. And that was at the end of 2018. Just coincidentally, we had learned that LPHI, Shalina's organization, was looking for a relocation opportunity. And we were also coincidentally working with a family and just completed a behavioral treatment facility, the redevelopment of a significant building on Broad Street in New Orleans. And one of the board members also had, one of the family members coincidentally was one of Michael's board members. Okay, so in terms of connectivity, there was a health connection from the beginning with regard to LPHI. Long story short, we were also independently proceeding to figure out a way to incent managed care organizations, which are healthcare insurers, to invest in permanent affordable housing rather than to simply throw short-term rental assistance to organizations when they were attempting to win competitively offered contracts through the states. The long story short, after our investigations, we decided that we would do 2 pilot projects, one here in New Orleans and one in Jackson, Mississippi, to demonstrate through data collection, through quantitative data collection, that if we provide accessible healthcare, can we get a better health outcome? Okay. Michael and team were then part of those discussions. Commerce, culture, and community, the 3 C's, right, became H3C. Okay, we were convinced we could embed health into our community practices, and we believe if we collect the data that we can demonstrate a better outcome. So that's kind of how we got to where we are. Unfortunately, as life happens, right, and life in our 4-letter word was a 5-letter word, COVID. And, this project closed at the end of 2021. You may know what that means in terms of timing, which was terrible. Okay, so, every day we opened our eyes and the price of the project went up. At the same time, Shalina's organization was also dealing with COVID, as was Michael's. Okay, and so the evolution of LPHI was they chose not to continue as a potential tenant or building owner on the site. And so we reimagined it, and we ended up, but Michael's organization, though, said, you know what, we still want to continue with this. We really are convinced we want to put a clinic on site. And so long story short, where we are right now, LPHI is involved, okay, in the partnership. They're not physically on site, but they are truly a partner in the redevelopment of this site and the data counting. And Michael's organization is now operating the clinic that is housed on site. So we finished the end of 23, leased up in 24. Both ventures are stabilized, and we are now beginning the data collection.
So I'll pick up from there and talk a little bit about the clinical side and the health center that we did co-locate on the campus. As Kathy mentioned, in that background, all of the process that went on in us connecting. But I also want to highlight again the interconnectivity of our people in the community. As she mentioned, she was working on a project, another project with a family, and that family member happened to be one of our community board members. And so we were introduced to this project. DePaul Community Health Center was introduced to this project by one of our board members. Now, DePaul Community Health Center is an FQHC, the largest one in the New Orleans area. We have about 50,000 members, both clinical patients, and we provide social services to quite a few of those individuals as well. And we were looking for a new location for several of our sites, our pediatric sites that were in the area, and roughly about a mile away. But the call came, and we happened to be in the market and thinking of how do we relocate and what partnership could we have to develop another space. Our model at our community health center, we like to include adult and pediatric care, adolescent care as well. And we also include behavioral health. We have dental services in some of our locations, but we also co-locate pharmacies. So developing a new site for one of our pediatric locations, which had 2 providers, we wanted to grow that, add adult care and add a pharmacy to the site. And so getting connected with Kathy and the C3 project gave us that opportunity to really think about that. Now, as mentioned, Kathy talked about the connection with insurance companies and MCOs, I think from the financing side, but from our standpoint, we connect with some of those same entities, organizations, again, from the clinical and care management and patient care side, insurance side of things. And so one of those companies that's connected with us in the community, we already had a contract with. So it's made it a lot easier for us to have a dialogue and discussion about data that we are going to collect from this project, mainly HEDIS measures that are really looking at how we can keep that population in this location healthy, but not only in the site with the housing units on the C3 campus, but the surrounding community as well. As a community health center, we provide care to everyone in the community, of course, and that includes those with insurance, Medicaid, Medicare, commercial, and those who don't have insurance. So our goal is to actually invite others from around the community and the residents that will be assessing and then also working with the data collection all to this site and this location. As Kathy mentioned, the construction was where we had to assess and look at things after COVID, and the expense went up. But we did have an opportunity, again, as that time went on, to really look at our health center project and then to really size that appropriately and think through how we would model that to better take care of everyone in the community. Price and cost did go up, but the other part of that is as Kathy's project was coming to a close, the health center project actually started and began in the health center space and the construction of that. So we opened actually early this year, January of 2024. We did the actual ribbon cutting. We opened last December. So it's been almost a year now that we've been in the space providing care to patients in the location. So we're very, very excited about how we will collaborate. Data collection is just beginning. How we will actually monitor and work with individuals in the community, and then also think through special populations. The location of this site is in a space and place where there are numerous potential partners that are in the immediate area. The New Orleans Mission, there is a actual very large church parish that is 2 blocks away. And then there's other community-based nonprofit businesses on Aretha Castle Haley that we intend to collaborate and work with as we continue to provide better services to all of those in the community. So I'll stop there and turn it over to Dr. Davis.
Yes, thank you so much, Dr. Griffin, and Ms. Laborde. So as was mentioned, so just some context. I came back to I was at LPHI post-Katrina, left and then came back in 2019, just as we were ramping up the process, as Ms. Laborde was sharing. My predecessor, Joe Kimbrell, and the team really worked to, understand how health and housing was interconnected. As a public health institute, I'm not sure many of you know, we actually have about 50 public health institutes across the country in most states, and then some states have a couple. And typically, our role in this space and in general is that of convener, connector, and data steward because of the resources we share. We do not provide direct services, although there are a couple of public health institutes that do. We do not provide direct clinical services, but really help to partner and support, health efforts that are happening across our community. As Ms. Laborde shared, in the fall of 2018, we joined local foundations, folks like community development organizations, folks like Dr. Griffin, community organizations, another data group that was based here in Greater New Orleans to collectively support the development of the project, recruitment of other tenants, and collaborative participation. And so because of the revenue, LPHI out of that group, particularly of the non-direct service providers, did have a good amount of revenue. So in the spring of 2019, LPHI submitted a proposal on behalf of what became H3C, as Ms. Laborde described, to the the Louisiana State Office of Community Development and other funding partners to request financial support for the construction. And so in the fall of 2019, we were participating in partnership with, Gulf Coast Housing Partnership and Alembic on like building design sessions. I'm not in the community development world, but I learned a lot. I think we were probably having, I don't know, weekly or bi-weekly meetings to really talk about this. And again, that was like when I first time as a CEO and first to the organization. So just trying to understand, and we were excited about the opportunity to be a tenant because as Ms. Laborde shared, our several year lease was coming to an end, and we actually had to get out of our space because they were converting our commercial space to residential space. So we had to get out. This would have been the first time that LPHI actually invested in a property versus leasing a property as well. So that we were excited about that opportunity. But 10 months into my tenure here at LPHI, as everybody knows, in March of 2020, COVID hit, and we actually went completely remote during that time. And we were completely remote for about 2 years. However, we had to, really, we met with a lot of the tenants actually that are already in that area to kind of understand like what it meant to be a landlord, because this would have been the first time LPHI would have been a landlord. We actually tried to understand all of the, various leases, like what would it mean to like not have, everything like custodial and all of that in our process on top of supporting the work in terms of, bringing the health data into this project. So we wanted to kind of share that. So the thing, like later in 2020, with lots of conversations underway, unfortunately, we just decided because of the timing and where we were in LPHI's journey, we decided to not be a tenant. However, as Ms. Laborde shared, we decided to continue the support role in partnership with other folks, like HMA is another group that's doing the evaluation. So a lot of the work that LPHI has done now since 2020 is really to help support the data and evaluation work that is happening both in New Orleans and Jackson, Mississippi. And I know now we're even in conversations to kind of like finalize our scope of work on the work that we're going to be doing over the next few years. And that will really include leveraging the data that we're talking about, the healthcare data from Dr. Griffin's organization, DePaul, as well as the work with the Medicaid managed care organizations. So LPHI houses and is a steward of, not an owner of, data infrastructures, a health information exchange, and a clinical research network, where we're able to compile data from many different, health centers and other hospital entities, as well as managed care organizations, to really ingest that information, match it with individual level data, and then we can establish like almost like what we call like a data enclave or a network through which an evaluator can securely access and analyze the data to evaluate the project's impact on health outcomes using measures that Dr. Griffin described earlier. So I'll stop there.
Thanks so much, Shalina. So can you guys talk a little bit about how community has been involved in this entire process? Shalina, do you want to start, or Kathy?
Yeah. Go ahead, Shalina.
Yeah, so I will just share from like the health standpoint. At LPHI, we really pride ourselves on partnership and collaboration, and that's not just with organizational entities, but also community entities. So even with the data and research efforts that we do, like evaluation, we don't not only pull in the data, the quantitative data pieces, but also pull in the stories from community members who are the ones, whose data we are stewarding, if you will. So I will share that, in that way, on the data side, that's how we do our work. I know, and I know Ms. Labor will be able to share a lot, but just from personal experience, I know firsthand, I attended community meetings that the community development organizations kind of facilitated to help support this initiative. So I think community was really involved in all aspects, from the data piece, as well as how we thought about what the project would look like. But I'll pass it to Ms. Labor to kind of talk more.
And I'll echo exactly what you just heard. The community, I think, has been very engaged in this neighborhood for decades. And when excuse me, Katrina gave the opportunity frankly for capital to be invested on the boulevard. And so I think it was really once people could actually honestly see that their dreams could come true, right? Because these organizations own the buildings, et cetera. They're the tenants, they're the landlords, et cetera. And it was really honoring the voices that were being heard. We had to hear the voices that were there, and so I think it's really not so much that this was new information or new needs from the community. It was finally recognition that these things could happen. And as they did happen, we then were almost like filling in the dots, right? We had businesses, we had restaurants, we did have some housing, but clearly, and I'm sure in most of your communities, there is no affordable housing is so lacking. Okay. And so that was something and that's why we bought the dirt. Okay. So that we could make sure there was affordable housing. But then what was it that we wanted to do to kind of put the icing on the cake? Okay, with the folks that had now the business is open, and make sure that we continue to invest to make sure there's people out there to continue to need the services and the housing that we're providing.
So I'll add a little from a community health center perspective. Our structure is very community involved and engaged, and the structure of an FQHC actually pulls in community involvement engagement at the highest level of the health center. And so our governing board, for example, and every health center's governing board has to have actual local community members that sit on that board. They represent the patients and constituents that are actually served. And actually 51% of them have to be users of the services. And so as we went through the discussion and dialogue with our board members, our monthly committee meetings, we have quality committee meetings, and of course, finance meetings and other, which all of our board members sit on. And then just the monthly board meetings. We dug into the discussion and dialogue and getting input from our community board members, and especially our user members, on services and quality and just all aspects of how to provide the care to community as we move from one location to the other. And as mentioned before, it was one of our community user board members that actually came to us with the opportunity because she had worked with Kathy the board on another project. And so that input and we have varying members. Some are business leaders, some have owned their own businesses, some are all aspects of socioeconomic income levels that sit on our board. Some are retired. We actually have some nuns because of our Catholic heritage and influence of 190 years of serving the community that sit on the board. And so all of that came into the dialogue discussion on how we could actually go into the location and provide the necessary services that would be needed, again, over time as we grow the location and provide additional services. Because we started as pediatrics, but now we've added adult and again, pharmacy and behavioral health services to the location, all with input from community board members.
Thank you all so much. So can you talk a little bit about the national dialogue? I know, Kathy, you mentioned briefly about like affordable housing not being in existence pretty much like in a number of different places. How has this national dialogue around affordable housing impacted this work?
Well, from our perspective, we're developers, right? And so, we're always looking for funding to to fill our capital stacks. And we're housing very, very low income people, and most of them don't have vouchers. So it really is very important that we raise gap money. Okay. And if you're familiar with our region along the Gulf Coast, there really isn't that kind of capital other than federal resources that come into the states. So it's a very competitive environment, and we're always looking for capital. Now, this is not unique to this area, but we don't have the players necessarily that some of our national peers do. So we really are trying, Jacqueline and audience members, to incent the healthcare industry, okay? Because we hear it anecdotally. Okay, you've all heard the social determinants of health. Housing is one of them, okay? And people like to throw those things around, right, when they're trying to get something. In this case, the MCO is trying to get a contract from the state. And so it was just kind of us recognizing, gosh, we are housing the folks that these groups are also serving. We have, we're both serving the same clientele. Okay. So how can we have the treasurer understand that accessibility to healthcare is valuable for a healthcare provider versus just the foundation side, or the marketing people that are trying to find a story to put in an RFP, right? And the way you do it is with data. And we believe, and frankly, if you understand how these contracts work, the states themselves are trying to incentivize better outcomes on metrics. They hold back some of the monies that are awarded to the MCOs, waiting for their performance measured by metrics and metric outcomes, right? And so we think we're on the right track. It's not going to happen overnight. And Jacqueline, we really believe that if we can demonstrate this, there's healthcare works nationwide. Okay. And so does this become a reliable source of go-to money? Perhaps, right? But I think we just have to give it a try.
Well, I'll add on the health improvement side. I mean, lack of stable housing is a healthcare issue. There are several studies out there that have shown the impact of lack of housing. And in so many urban areas and communities, there is a lack of affordable housing for low-income populations. And so I think healthcare insurers and organizations are understanding this and are thinking through ways and trying to look at ways really of solving needs that ultimately could impact their bottom line. As an insurance company looks at and comes to the table and says, okay, I have a person that is going to the emergency room just higher than average. And what are those social drivers of health that are impacting? And a lot of times that is housing, of course, finances, and so many other things. And so looking at alternative ways of taking those dollars from some of those organizations and really addressing some of those needs so that we could lower cost over time, I think that is getting the attention of national funders and insurers and foundations and public entities, government entities as well. Because at the end of the day, I think like the state of Louisiana with Medicaid, the federal government and others, all are actually chipping in dollars and cents that are going into the inefficiency of healthcare. So how do we become more efficient? How do we really look at a holistic approach going upstream and working with individuals where they are, meeting them where they are, and then looking at things like housing, food, and educational attainment, workforce, and increasing in household incomes. A lot of that starts with having a stable house and household and a housing situation for a family. So this helps to address that. There's studies out there that show that there's impact, and we're going to help to collect more data to help to prove the need.
And if I might add, one thing I did not mention, I guess I'm kind of assuming that folks know this. We're looking for concessionary capital. Okay, we're not looking for market rate capital. We're looking for concessionary capital from the healthcare industry. And they can really provide this in two ways. They can pay a premium. Some healthcare providers are investing in affordable housing through low-income housing tax credits, right? If they can pay a premium, that's a concession, right? We're also borrowing from them though. Okay, and so what we're asking them to do is we want to borrow the money at lesser rates than if we went to our conventional lenders. Okay, so it really is not enough that they invest. They have to invest in a way that advances the cause. And as Michael said, if we could demonstrate through data that our residents and community members that access the healthcare because it is more accessible, they get a better health outcome and at a lesser cost because those people are no longer running to the emergency room. They're getting immediate health care. They're getting knowledge. They're getting awareness of how to take care of themselves in a proactive way. And all those things add up. And if we can be the bean counters for the healthcare industry, along with the health outcome, we believe we have a compelling case or may have a compelling case.
Yeah, and I'll just add, I mean, obviously ditto to what was already shared. And I know the question was around national dialogue impacting affordable housing. But as you are hearing, New Orleans is a small, tight-knit community. Many of us work together, play together, pray together. So it had, being a public health organization, obviously we've been in the conversation around like housing being a social driver of health. However, so many people, as you share, like even from community development and from housing orgs, actually are asking us to say like, hey, we want to frame this as a public health or health issue, and are already coming to the table with that in mind. As you see, even, with Ms. Labour's group, that's how they came into the conversation. So I just wanted to kind of highlight that because we've been talking about this, social determinants, social drivers of health as housing. I think it's already, especially on many of us who work in the nonprofit sector, it's on our minds, even if we don't work in housing each and every day. I'll also add too, because I know, again, being new to the space, one of our organizations that we pull a lot of resources and information from is the Building Healthy Places Network. And they're a group that's a part of the Public Health Institute based out of California, which is one of our siblings, as we call them lovingly. And they do a lot of work to really transform how organizations from community development, from financing and health work together. So I know like a lot of the resources and tools that as we were doing our research for this initiative really came from that. So I wanted to also elevate and highlight the work that has been done, nationally, and also that we're bringing as a resource here in the space.
Thanks for that, Shalina. Yeah, Build Healthy Places Network is one of our partners as well. So shout out to Colleen and Ruth as well. When we think about the number of years that this has been, this collaboration has taken place, can you give us an idea of some of the lessons learned or missteps and anything that you would like to share around kind of the lessons learned and barriers to implementation and actually getting people into the door for the FQHC as well as into the apartments as well?
Well, since you mentioned the FQHC, I'll jump in and Anytime you move, we move from one location to the other, there's an awareness that is needed. I also I think through, because we do have another location that's actually adjacent to a public housing location in the city. And I'm always thinking about, does an individual want to go to the health facility so close to their home? And so those are some of the things that we're going to be observing, taking a look at, assessing, and thinking through how we market, how we look at those individuals and services that we are providing. What other options can we give them? And it's just fortunate that our organization has 11 locations throughout the community. So even if the individual does not go to the site that's on campus downstairs, they can be a part of DePaul's health services and network in our system and go to another location. If some of the individuals go to some of our, so they may have some kids that attend some of the schools. We're in 23 schools. So access and capture of patient populations where they serve or where they are, excuse me, in schools, and in this case, even where they live and home, is the goal, but it also can be a challenge. Lastly, I'll say we did start the process and project, and Kathy was much further along with the process and dialogue when we came aboard. And so we had a separate contractor. And so I just say from a construction side and working with, they had a contractor, and then we had a group and contractor that we brought in kind of after that to build out our health center space. But having multiple contractors aligning and timing things so that we can be most effective and efficient can be a challenge. And so I'm just, from a practical standpoint, that has been one of the things that challenged us a bit, actually, coming in after the initial contractor built the envelope in the total building, and then we came in to build out the health center space, and then aligning all of the dialogue and communication, and who does what, where does one group begin and one end, took some additional conversations.
Yeah, and I'll just share from our, standpoint, not like we always say, we can't do any work to advance health in our community by ourselves. Like it takes all of us. It doesn't take a single organization to address these types of public health issues or others around housing, or other social drivers of health. So I think, what we kind of learned is the importance of not just bringing public health and healthcare to the table, but also there's community development, financing folks. And just as we're kind of providing our expertise in the area of like data and how health and housing are connected, we were also learning a lot about like financing and all of these, like terms that Ms. Laborde and her team kind of shared and what that actually looks like for us. I'll also share, and I don't know if this is a challenge, I don't think it's a misstep, but just, even in looking back and reflecting on like what we could have done differently, as a nonprofit organization, many of us are funded in different ways. As a non-direct provider, our organization, although if folks look at like our 990, we look like we have a large operating budget, which we do, we're in the tens of millions. However, like 90-something% of our funding is restricted to the programs. We don't have a lot of, like, we're not flush with like unrestricted cash to support, efforts like this per se, even though we could, apply for financing and things like that. But I think one lesson for me would just be, how can we work on like capital campaigns, or even, looking for like unrestricted funding that wouldn't just help support the year, but like even beyond, and just working with organizations more to learn about those unrestricted funds that would help us be more comfortable saying yes to an opportunity like this. I'll also share, because there may be other nonprofits on the line, much of our, like a lot of our funders are cool with, like a lot of our funds, probably about 85% of our funds actually support rent. However, when we went to a mortgage, it would have been like individual negotiations with our funders. And we have like tens, maybe close to 100 funders that we would have had to talk to negotiate them, you know, transitioning from rent to mortgage. And these are just things that we never really thought about in terms of like the nuances as we were uncovering just financing for the for like becoming a tenant. So I just wanted to share that because I know, you know, it was a lot of conversations with finance and other nonprofits to kind of learn of those lessons.
And I will share, I mean, this is a lesson that I'm sure many of you already learned. You have to adapt. You know, you have to adapt if you want to move forward. And, you know, you start sometimes with where you think you're going to head and things happen. And it doesn't mean you alienate those around you. It means you got to figure out a way forward. Okay. No one expected the economic environment. No one expected COVID. No one expected, you know, construction prices to go sky high. No one expected the insurance market, okay, to drop. I mean, I'm not sure if you know what's happening in Louisiana, but unfortunately, people are leaving the state in droves because we can't get insurance. You know, so you have to be able to weather all that. And I wish that was a lesson I didn't have to learn. Okay, but it is, and you just have to surround yourself with folks that have integrity, that are like-minded in the mission. Okay, because you know, I think Shalene is a perfect example. LPHI didn't give up on the mission. They figured out where they could best fit in given their own organizational ambitions. And I think that's really, really important.
Thank you all. I'm wondering if we could talk a little bit more about the alignment of experts that were at the table and the trust that was built like during this time frame. Shalina, you mentioned finance and of course public health, community development, and health at the table. Were there other experts at that were at the table outside of the ones that you already mentioned? I'm thinking that folks may be interested in knowing who's been in conversation and still involved as partners in this work.
Yeah, I'm recalling Ms. Laborde, the architects that I think
I'm so glad you brought that up.
Okay, yeah, I was thinking about them. So yeah.
Yeah, really, this was the first Fitwel building. Fitwel is a building certification for healthy buildings. Okay, and we decided that that was important because obviously we're trying to have a healthcare face. And the architects we brought in, we did some digging and we brought a company in from Austin to partner with a local architect. And we had a wonderful design. We just couldn't afford to build it. Okay. So, you know, again, but we learned from them. We learned the important Fitwel ingredients, right? And both this and the building in Jackson are both Fitwel certified. So that firm was an important team member in frankly pushing the envelope, even with our own architect. Okay, and probably having a more creative outcome. We scaled it back a lot, but we have a public health consultant. Okay, so that person has been very important in terms of driving and keeping everybody at the table. You know, the note taker, who convenes, who makes sure that they're taking notes, who makes sure that you follow up. Those roles are really important. Okay, and that frankly, the MCOs themselves, they're at the table too. So, you know, it's important that these relationships are maintained along with the FQHC there at the table. So it's a lot of folks around the table, and they're competitors, by the way. There's two different MCOs involved here. There's two different health clinics. Everybody's agreed to let LPHI, okay, have the role it has, even though half of these folks are in Mississippi. You know, so there is really a collaborative spirit here because I think the folks involved recognize what we all are trying to demonstrate.
Well, I'll add again, I can't highlight enough, Shalina mentioned financing, but Kathy's expertise just in tax credits. That is a very complicated endeavor just to venture into and understand. And Kathy mentioned housing credits, which I have no clue about, but have worked in the new market tax credit, both at the federal level, state level, historic tax credit space. So some of those experts that have been at the table, at least from our end, because we had new market tax credits that came into the health clinic as well, were those tax credit attorneys, accountants, and experts that help to coordinate all of the work that goes into facilitating the credits, understanding what needs to happen in timing wise, and leveraging all of that both at a federal and state level is a daunting task, which something we couldn't have done if we didn't have those experts at the table helping to coordinate that for us. I'll just say that we actually coordinated 3 projects at one time. This was one of them, but we also had 2 other freestanding sites that we developed along with this and brought tax credits together with all of those projects. And so it was interesting to get the input from all those experts to really figure out how to pull that off and do it, and make sure the timing happened in an expeditious way.
Thank you for that. We're going to now open it up for questions. So if you do have a question, you can put that in the chat. I think Kaniqua had mentioned that earlier, but if you have any questions for the panelists, we can address those now. So feel free to put that in the chat. I can ask another question while we wait. Given that, Shalene, I know you're kind of state of Louisiana, but I guess from a regional perspective, and then Michael and Kathy, because you have locations in a number of different states, are there similarities, I guess, around like the regulatory environment and then trying to get something like this accomplished? Have you seen, I guess, what are the politics like for you to be able to balance regionally and probably in other states too? Do you utilize some of the best practices from some areas to help you with others, or how do you try to utilize what you're seeing in other places?
Yeah, so I mean, I'll start. LPHI, although we are statewide, we only have like one office that is headquartered in New Orleans. So that's why we were looking at a space there. For our regional staff, they actually kind of work, like we have a relationship with the health department's regional staff, and they allow us to kind of like in-kind lease space, not lease space, but like in-kind let our staff who are headquartered in those other regions use that space. So, just wanting to provide that context. I will say just anytime we navigate working, across state lines and in other regions, we always go in with partners who are from those regions, and really kind of, I would say, even defer or build relationship to see, like, we kind of let them lead the way and like invite us to kind of support in the ways that they need. So I feel like even, I'll talk, I'll let the others talk more about Mississippi, but with anything that we do, it's more how are we intentional in building relationships, and especially if we're not in a space and we may not understand all the politics, we kind of let the folks who understand the politics lead the way and we support, if that makes sense.
Erica Bryce, I see you have your hand raised. Can you come off of mute and ask your question?
Man, I had to type in the chat.
There we go. Okay, can everybody hear me now?
Hi, Erica. Yes.
Hi, sorry, I'm trying to get my camera to work. That's not working either. So many questions. This is fascinating. I'd like to start with asking a question about the process of working on the financial side with the health entities. Can you all talk a little bit more about who you had to talk to on sorry, not the health side, but the insurer side, right? Or the payer side? Who did you have to talk to in terms of financing, and especially on the MCO? And what were those conversations like? Did you all have to kind of translate, I guess, language between health versus financing versus community development. I'm just curious more about how that process went.
Well, in different ways, okay? In the original, what do I say, our original path started in Mississippi. And through the group we were partnering with, we met the fellow that runs the MCO office in Mississippi. And then who got it, and so it was really about conversations. And so you went from the president of that office who, when we explained what we're doing, then you bypass the salespeople. He connected us to the treasurer's office. This is, believe me, folks, it sounds simple. This has taken us years, okay? These conversations started years ago, okay? These conversations started before community health workers were reimbursable by the federal government, okay? And that was really we saw what was happening and that this was an effective model of health service, this community health worker model that could not be reimbursed. And so it was kind of like, this is kind of silly. How do we get people to understand this really does work, right? And so it was those conversations, because the MCO also recognized it was worked. It was in their best interest to figure out how to get the federal government to reimburse for that culturally competent healthcare worker, right? So, and then on the other MCO side, there was a specific person, and I don't remember the title. Okay, I would guess that most MCOs have these roles, where these are the faces of the organization. They are out there developing relationships, because these relationships are key in building the response to the RFP to get the state contracts. Okay, so they are working in the field. They are the community health face of the MCOs. So you should reach out to those people. I'm sure they go to every health convention there is, or so just pay attention. Or if they come knocking on your door, or somebody's door in your building, maybe it's the service provider side. Specifically, they're going to offer short-term rental assistance to homeless providers. Okay, I understand that is a big need, but that doesn't give you permanent housing. But if you get that business card, right, you'll understand they're interested in your job is to question, why are they interested? Okay, and then use that to just keep pushing beyond that. Oh, now I know that they're competing for a contract. Okay, how can we begin to work this in a way that's beneficial to both sides?
Well, I add to that too, and I wasn't in those conversations with Kathy, but I will tell you, I'm in daily conversations with MCOs, and all of our NCOs that are in Louisiana or national organizations. So again, United, Aetna, Elevant, which is Healthy Blue in the state. And so they all are leaning in and understanding what really, again, impacts the health of the population that's being served. These entities came into the state of Louisiana. They had commercial plans and other plans, but they've now expanded some years ago to Medicaid MCOs. And so, they're focused on the lower income population and managing that population in the best way possible. And again, a lot of times for us, that means working with FQHCs in those states, which that's the work that we do. 90+% of our patients are under 200% of poverty that we see across the country, and we're in all states. And so having the dialogue with MCOs and understanding and getting them to understand that what investments can be made that has a return on that could actually help improve the health status of the patient population. And a lot of times from a state standpoint and a federal standpoint, it's very hard to get dollars from Medicaid or Medicare over to things like food and housing and other. There's processes to go through that could happen, like 1115 waivers, but it's hard to do that. But MCOs have these agreements and contracts, and probably have more flexibility once they are have some contractual relationship with the state, especially for Medicaid. And so I can understand how they are going to lean in probably that much more into keeping populations healthier because the dollars just aren't going to be there to fund patients that aren't used to having a medical home going to an emergency room every day. Don't have housing, but they're still on your panel for healthcare and may cost over $50,000 a year in healthcare dollars going through the emergency room and inpatient facilities, when some of those things could be, they're just not housed. They are sick from being out on the street every day and need to actually have their care coordinated through an entity like an FQHC. So I think the dialogue is going to grow with hospitals, insurers, and other types of potential partners. And I'm glad that that's going to move forward. But I think the data, again, going back to that, and what we can get from this partnership is going to help with proving the case to do more of these type of investments throughout the country.
Thank you. Mary Williams Stover, you have a question as well?
Yes, yes. Thank you for taking my question. This is a fascinating conversation. I'm with the Center for Black Health and Equity, and we're a nonprofit organization that works with communities to build capacity through programs and services. And Dr. Davis certainly mentioned the value of evaluation. And my question has to do with two aspects. One, in terms of evaluation, we've learned that, as I think she mentioned, hearing the stories of people's personal experiences is golden, right? And then how do you capture those experiences in a way that they inform improvements in the overall process? Because I hear what you're talking about with kind of a whole health focus and perspective, but the stories of individuals who are accessing services is really where the rubber hits the road. So I'd love to hear more about how you plan to integrate that evaluation. Thank you.
Sure. I mean, I can speak pretty high level because I know we're still working through the scope with Ms. Laborde's team, but I know, LPHI is going to be working with another public health consulting group to do the data and the evaluation piece over the next few years. Just in terms of how LPHI approaches our data and evaluation work, it is always from like a community-centered lens. Any of the assessment work that we do either with hospitals or, in partnership with the state or with our local folks to kind of inform health improvement plans, we've always not only like used the quantitative data, but like as you shared, we're always trying to figure out ways to kind of incorporate the storytelling. I will share with you, the qualitative piece does cost more money a lot of times when we're doing that, because it does take resources to not just we know where the community members are, but because of the information they're providing us, we also want to incentivize and compensate people for sharing their stories, which oftentimes, we have to, go back and forth in terms of like the funding. I'll also say through one of our research infrastructures that we may be using for this, the community centeredness is actually, or like the patient advisor group is actually a part of that clinical research network. So we have folks that we can kind of pull from there. So it's definitely like evaluation's always a question. I know many funders don't even pay sometimes for evaluation, especially qualitative. So I think it's just an ongoing conversation. But I don't know if Ms. Laborde has more to add to that.
Yeah, I will say, independent of what Shalina is talking about, we are also collecting stories, resident stories, and frankly, seeing how their behaviors are changing and making sure we capture that. We capture in video, we capture it in interviews, okay? In H3C and the Pearl, there's monthly community meetings. I think it's important for people to understand you are not forced to go to the healthcare clinic on site. This is really, you have to opt in. So there is a lot of education going on, and it is about building trust. Okay, and we take so many things for granted from the healthcare side that we assume people are comfortable with certain things. We assume people trust professionals, and they don't. Okay, and so there really is this cultural linkage we make. It's not just the community health worker; it's a maintenance guy this happened at the Pearl in Jackson. He noticed one of our residents' ankles were swelling. Okay, he convinced her to go to the clinic, which is like 20 feet away, right? You know, he's not a trained professional, right? But he established a relationship with her, and guess what? You know, she's going to have a better health outcome now. But we need to collect that story because people relate to numbers, but they also relate to real human beings and how people are being impacted. We need them both.
Absolutely. Suzanne, did you still have a question? I know you had raised your hand.
Yes, I do. I was working with the group with Amy Steele in New Orleans with the actually traffic, getting rid of freeways. And there is a lot of gathering of information there. And I was wondering if you actually work with her at all, because she's working with the University. I'm not sure which university with gathering information for that. It seems like it's a lot of the same kind of data gathering, and we have it in Rochester the same way. And who's got what data, and how do you actually find places where it's in one place and that you don't have to go to 4 different places?
I'm not familiar with, you said Amy Steele?
Yeah, she's working, been working in New Orleans with trying to actually work on health problems because of the highway bridge over,
Right,
and
right.
trying to find ways that helps you.
Yeah, I mean, I can't speak to what Amy is doing, but the whole kind of data infrastructure that LPHI kind of stewards and doesn't own, but is an attempt to kind of compile information in a way that folks can go to one source, even though it's many different sources feed into those data infrastructures. And even for example, on the Health Information Exchange, which is a subsidiary organization that like even Dr. Griffin serves on that board. It's a number of organizations that are feeding in the data to do exactly what you're talking about. Like, so it's not just like 100 different places folks have to go, but they can go to one place where the information is shared in ways that, ethically and with in a secured way and aggregated so that folks can use it for what it's supposed to be used for. In this case, determining how housing and health are impacted. So I will share that these data infrastructure are an attempt at combining all of the data assets in this region and beyond to kind of support that.
Thank you. Also, I'm wondering about
Suzanne,
the
I'm sorry.
future.
We're actually
I'm
at
sorry.
time. Yeah, we're over time right now. I want to be respectful of people's time because we only scheduled for an hour. So I wanted to thank all of the panelists for your time and also your willingness to do this in December when we were scheduled for September. I really appreciate you guys taking the time today to do this and to share the amazing work that's happening in New Orleans. And with that, we're going to conclude. If there are any other questions, feel free to email me, Suzanne, and I can get these questions answered for you. But again, thank you all for joining us on this call. And thank you for celebrating. I think this actually wraps up our Centennial celebrations for the year. So thank you for being here to celebrate with us. I hope everyone has a safe and restful holiday season and Happy New Year. Thanks all.
Thank you.
Thank you.
Thanks, everybody. Bye-bye.